So guys, today I'm about to do a mock VIVA exam. A VIVA exam is the final exam at UNSW Medicine. So it's the barrier before you become a doctor. So it's pretty intense and we're pretty lucky to have a mock one today. This will be pretty similar to the real thing because the real thing will be online and this will be online. So there's going to be about 6 or 7 stations. I'm not sure how I'm going to do. I'm a bit nervous, to be honest. I won't show you all 6 stations, but maybe I'll give you an example of one station where I do well, and maybe I'll give you an example of a station where I don't do so well. And then we can analyze it as we go, so I can review my performance and talk about things I should and shouldn't have done. All right, guys, if that sounds good, then let's roll the intro. Boom! So at the end of medicine, there's a bunch of different exams you have to do. You have to do a big multiple choice one. You have to do an OSCE, which is where you basically take histories from patients in front of examiners to show them that you can take a history from a patient. You might have to do an examination as well, like a knee exam. And then there are VIVAs, which is what I'm practicing today. Now a VIVA is essentially 2 doctors sitting behind a desk and they give you a case stem. So for example, it could be a 20-year-old female who's pregnant, is presenting with per vaginal bleeding. Describe your assessment and management. And then you, as a student, have to speak for like 10 minutes about what you would do if someone presented with this. Like, what would you actually do? And you describe to them your assessment of the bleeding, your examination of the patient, the investigations you would order, and of course the management options you would go. So there's a pretty solid structure. What I really do like about this exam is I can look really nice, but actually just be in my comfy socks and my shorts. It's like business up top, party down low. All right, we're gonna jump into it now, so let's go. Okay guys, just finished up the exam. It went pretty well. I passed overall, so that's good. Embarrassingly enough, I forgot to film for a lot of it. So I only actually got the last 2 stations, which were surgery and obstetrics and gynaecology. I did pretty well in surgery. It's not my forte. I don't know if I have a forte, but if I did have a forte, it wouldn't be surgery or obstetrics and gynaecology. Got a borderline pass. Let's begin. Okay, I'll start with the first case. We've got a 60-year-old female. Okay, so my impression is we've got a 60-year-old female with post-operative fever. She's 39 degrees. And the big concerns here is she infected? Is she sick? And so we are concerned about an abscess, a sepsis, a bacteremia, a peritonitis, and all those sorts of things. Look, 3 days, you don't expect a malignant hypothermia that far after anesthetic, but you keep that on the differentials if it was closer to the surgical date. So those are the differentials to consider. My plan for... So worth taking a quick break to give you an overview of how these VIVAs work. The structure is almost always the same. You get given a stem. So in this case, it was a whatever-year-old female who has just had surgery 3 days ago, and she's now got a fever. Now, a fever can mean a wide range of things, but most likely it's an infection. So what you say in your VIVA is you start with your impression. So your impression is it's a 3-day post-operative fever in a 60-year-old female or whatever it is. Then you say what your differentials could be. So I said abscess, peritonitis, sepsis. I made a big error here because this is something I know well, and I use the source mnemonic for infections. So this is really a good tip if you ever want to have a good differentials for infections. Source of infection is what you're looking for. So a fever with an unknown source. S, skin. So that's IV cannulas, any cellulitis. O, osteo, bones, joint infections, bone infections. This is less common, but it fits the mnemonic. U, urinary tract. So this is renal, UTI. R, respiratory. Now this is really common post-op, okay? Aspiration pneumonia, atelectasis, a respiratory source for infection is really common, and I really should have said that here, but I didn't. C is cranium. So that's things like meningitis, encephalitis. That's pretty uncommon post-op. Depending on the operation, but the surgery she had was a hemicolectomy, so an abdominal surgery where they remove part of your intestine. So it's not going to be an encephalitis, which is an infection of the brain. And then E is enteral, so enteritis, so gastroenteritis, so source mnemonic. that's yours. Keep it, enjoy it. So that was a missed opportunity where I could have demonstrated my knowledge, and I didn't because of factors like time pressure and being on the spot, that kind of thing. Let's keep going. Would be to do an A to E assessment. I do take this situation pretty seriously. It's also worth mentioning this could just be a postoperative inflammatory state. Big hemicolectomy, lots of cytokines. You can just have a fever routinely, but the concern is that there's an infective process going on with her. So as I said, A to E assessment with quick antibiotics, fluids, and resus if needed. And then sorry, just to make sure you guys don't think I'm cheating or anything, you get given 1 minute of reading time, which I haven't shown. And during that 1 minute, I've put out a plan of what I'm going to say for the case. So although it's pretty much freestyling, you do have about a minute to structure your response. I want to take my history, examination, and we can talk about investigations and management later. Now you wanted me to focus on the history and examination. Should we assume the AD assessment is stable, blood pressure is normal, not normal, and normal? In her STEM, she asked me to focus on history and examination, but someone who's got a post-op fever, it's important to do an AD assessment. So I'm just clarifying with the examiner, putting the ball into her court to lead me where she wants me to go. I think that's fine during a VIVA to put the ball in the examiner's court if they want to direct you in any specific direction. And then she tells me that there's actually she's becoming hypotensive. My red flag would start firing at a tachycardia and a borderline hypertension. So I'd probably go to A to E and get help pretty soon. But in terms of the history, I want to do an ample really quick. I want to know allergies, medications, when was her last meal, if she needs to be reopened, and past medical history, past surgical history, especially past surgical history. So we've got this one, have there been others, and anything else I find relevant. She's 60, so I'm not concerned about, anyway, that's fine. So that's the quick stuff. I need to get that out of the way. Then I can take a bit more time characterizing this fever. When did it start? Did she have it beforehand? How's it progressing? Has she ever had post-op complications before? I need to review the surgical notes, of course, for blood loss, for risk of infection. I need to call the surgeon relatively soon. They'll have a good understanding as if there's a high bleeding or infection risks. I accept that this is not looking like a bleed, but rather an infection, but it's important to keep a wide mind. So that's really getting to understand the situation. We're reviewing the vitals and we're looking at systemic signs like the fever. So that's the quick kind of history. And we reviewed past medical stuff. Look at the medications. Instead of saying that's the quick history, say that's the focused or targeted history. I'm pretty happy with, all that seemed pretty appropriate. There was one point there where I was a bit mind blanked. I had an idea and then I didn't pursue with it. That's okay, that happens. And you just don't want to dig yourself a hole when that happens and move on to the next thing as quickly as possible. Your recovery from making mistakes is very suggestive of how good of a speaker you are. Big public speakers all make mistakes when speaking, but it's how they recover from those errors, how they kind of even when there's errors with the electronics, all those things, it's how they recover that shows their level of skill. So far I'm happy with this performance. I mean, it's not this is not the top of the year, and that's not why I'm showing you this, but it's good enough. She have the antibiotics during the surgery, and that kind of thing. And is she at risk of infections as well? Is she type 2 diabetic? Is she on immunosuppressants normally? And all that sort of thing. So those are really important questions. Psychosocial history, not so important right now. Family history, not so important right now. We'll probably move to examination. Really important to observe the scar, make sure there's no pus coming out, make sure it's not too erythematous. We're feeling for peritonitic signs. If it's a soft, non-tender abdomen, that's reassuring. Also palpating, but gently for abscess or anything like that. But that's pretty unlikely. And probably she's pretty tender after the surgery. Lactate, cultures, sepsis pathway, and swab of the wound site. And in the last minute, I guess we'll just talk about early antibiotics and fluid. Essentially, we want, if she's becoming hypotensive, normal saline, 500 ml bolus, see how it responds. and hopefully we get the VBGs back and we can see if the lactate's high and if this looks like sepsis. Yep, and then we want to start antibiotics soon. AMP, jet, metronidazole are the common three, especially with metronidazole, because of those gut anaerobes, which might be the cause. And if we think there's other sites for the infection, like aspiration pneumonia, we need to do other imaging of sputum, UTIs, and CNS infections as well aren't uncommon. All right, that's 5 minutes. Yeah, in the last seconds, I talked about other sites of infection, so I left it too late, but at least I mentioned it. All right, so overall, I was pretty happy with that. Obviously, I missed some things. I've kind of accepted that I'm always going to miss some things. It's impossible, unless you've memorized the case, to just remember everything that you are going to do. The key is just to speak well and then maybe leave a minute or so at the end to let the examiner ask questions. She was kind of hesitantly interrupting there, so I asked her if she had any questions she wanted me to answer. That also displays a sense of confidence, I think, because it's I know this case so well that I'm happy to accept you to direct me in any direction. Anyway, so that one I was pretty happy with, but let's now look at one that I got a B, a borderline pass, which due to complex technical things that I don't understand, a B is essentially a fail. So it's no big deal that I failed, I don't mind. This exam is in a month and a half, so I have plenty of time to prepare my obstetrics and gynecology, which is my weak area. If you want to support my small channel, please consider subscribing. It would really help me out, but also it validates that what I'm doing is valuable, and so I should continue doing it. If you don't think what I'm doing is valuable, please give me some feedback as to what you think would be valuable, and I can play around with trying to do that. But let's talk about the next case. The next case was a female who was 24 weeks pregnant, and she was presenting with pervaginal bleeding. And then the question is, discuss your assessment and management. Now that's it. So this case I found challenging because it could have been a lot of blood or a little bit of blood. It could be, something very serious like placenta previa, or it could be something pretty minor like trauma from sex. Because in the second trimester of pregnancy, your cervix actually is more friable and it bleeds more easily. Anyway, that's all in hindsight because I didn't really talk about that stuff very well, but we'll see. And that's my minute. I wish I had more. All right. Okay, my impression is that we've got a 24-week pregnant 30-year-old female, and that she's got some PV bleeding. Now, there's a lot of differentials that can cause PV bleeding at 24 weeks. Concerningly, miscarriages, possibly placental previas with a premature rupture, so premature. So, a couple of things. It's not called miscarriage if it's after 20 weeks. It's called a fetal loss. And this was one of the big mistakes that I made because I proceed to talking about the management of miscarriages, which is with a dilation and curettage and medications like methotrexate and mifepristone. So if I had known that, I could have done better in this case, but that was one of the areas I lost marks in. We'll see. You'll see. Rupture of the membranes, and things like trauma, other rarer things like cancer or infection or depending on what the bleeding is characterized to be other things can be considered. But let's continue. With my plan, I'm actually going to start with a bit of an AE assessment and essentially ensuring she's hemodynamically stable because this could be heavy bleeding and that would be a kind of emergency, of course. And if she's stable, then we can spend a bit of time doing our history exam, characterizing everything appropriately, ordering the right investigations, and then managing, which could be anything from a massive transfusion protocol to DNC, or not DNC, but termination. It could be a lot of things depending on what the story tells us. So let's begin. With the AD assessment, the big concern here is hemorrhagic hypovolemic shock. And we probably get that pretty quick on an ample history where we want to know the allergies, past medical conditions, past surgical conditions, last meal, and everything else. And in everything else, we want to know about how much blood is coming out. If this is bucket loads of blood actively hemorrhaging, we're going down a totally kind of emergency medicine pathway with transfusions, fluid. So this is a challenge with stems that have so many different directions you can take, and often the examiner will guide you in what direction they want you to take. This examiner was just muted for the whole time, and so it was totally up to the student to kind of decide whether this was going to be a case with a lot of blood loss or a case with a little bit of blood loss. So I found that pretty challenging, and I didn't do that well. You could tell that I just kind of was jumping between whether it was a case of lots of blood, which would be emergency medicine, or a little bit of blood, which would be more obstetrics and gynecology. It's vasopressors and emergency obs and gyn consult. Assuming she's hemodynamically stable, and this is just smaller amounts of blood, then we can spend a bit of time doing our history. And of course, monitoring vitals throughout will be really important for this. Jumping back and forth between characterize. Things. How much blood? When did it start? And what has it been associated with? Use the Socrates framework to be thorough, but things like, has it been associated with a decrease in fetal movement? Has it been associated with acute onset of pain, pelvic pain? Asking about whether so that's characterizing the amount of blood, and is it associated with pus or malodor? Is this taking us down a kind of infectious pathway? But asking about past obstetric history and medical history will be really important here. Has she ever had this with previous pregnancies? What did it turn out to be? She's 30, but 30-year-olds can get cervical cancer, so we do want to consider that she's up to date with a cervical screening, and we can ask about risk factors. In the feedback for this, I actually got grilled on it. I thought that was, I still think that's a pretty fair point. Like, obviously it's super uncommon that this is going to be cervical cancer, but I don't think I should get marks taken away for bringing it up. I think, and I acknowledge that it's not common in the thing, but sometimes you're just going to have harsh examiners as well, and they have all the power, and that's not exactly fair because, you know, a lot of this stuff is nuanced, but whatever. I totally admit that there's things I don't do well here, but I don't fully admit that was a thing that I should have had marks taken off for. Factors for cancer, I guess: weight loss, anorexia, fever, fatigue, myalgias, that sort of things. Although when you're pregnant, you get a bit of those things. So every time I talk cancer and the systemic signs, I talk about weight loss, anorexia, fever, fatigue, myalgia, and night sweats, and I say them really quickly, and that can sometimes impress an examiner, and that's just because I have a mnemonic which is WAFM, and I kind of think of like, you got to whack 'em, you got to WAF 'em. Weight loss, W, anorexia, fever, fatigue, myalgias, night sweats. So WAF 'em, and that's just a quick way to get all the systemic signs that are associated with kind of systemic illnesses such as cancer. Like myalgia. But you wouldn't get weight loss. So that's the past medical history. Yeah, past obstetric history. So how did the other pregnancies go before, during, and after? Like conception, fertilization issues, any issues during the pregnancy. Just talking shit after, here. And match them up to this pregnancy. How's this pregnancy going? I should have asked about previous C-sections, by the way. Sorry, not GBS. GDM, so any issues with diabetes. What's diabetes going to have to do with bleeding? Hicks contractions. She's 24 weeks, so she might start having them. Making sure her blood pressures have been normal. And that's good. Yep, no, because you can get HELLP syndrome, that'll be all very important. And past medical history. Other considerations, of course, are if she's got hemophilias. Nice. Okay, type A, type B, von Willebrand's disease, those sorts of things that make you high risk of bleeding. Saving it. And then do the rest of the history, be really thorough, but I'm just conscious of time, so I'll just be brief. Family history of similar events, psychosocial history, making sure she's well supported at home, and any medications that, you know, maybe she's on anticoagulants for whatever reason, and that could be an issue with PV bleeding here. Not as a cause, but as an exacerbating factor. Now let's talk about examination. For 24 weeks, we can obviously palpate the abdomen now and measure it from the pubic symphysis. And first you do, the end of the betagram. You observe the female in full, see how she's looking. and then you want to do your obstetric exam. You can be thorough and do a cardiac exam as well if you like, but the obstetric exam is look, palpate, look for fetal movements, and that sort of stuff. I think now is a good, so you've done your obstetric exam. You need to do a speculum here. You need to do a PV and a speculum. I would talk to my reg first before doing a PV. If this is at risk of being a premature rupture of the membranes, I'm not sure.
Or a placental previa, by the way. You don't want to do this.
The same information from an ultrasound.
Do an ultrasound.
So I would talk to senior to senior clinicians before doing my PV and speculum. With the speculum, if it's deemed appropriate, I'm looking for the source of bleeding. Is there active bleeding coming out of the cervix? Or does it look like there's tears or trauma on the outside in the vaginal wall? Or, try and identify the source as best you can. And then we can talk about investigations. Investigations, you want to have the monitoring, so you want those cardiac tachography monitors for the baby and the contractions, see how that's going. You want to assess fetal heart rate with the machine that does that, and of course you want to do an ultrasound. She definitely warrants an ultrasound. With the ultrasound, you're looking if there's any blood between, if there's detachment of the placenta, if there's abruption, if there's any risk factors or any sources of like blood clots or anything like that. And you want to make sure that the heart is beating of the fetus and that they're moving and that sort of thing. That's the ultrasound. Any other imaging? I don't think so at this stage. So management. So the management really depends on a lot of factors. So management, if it's an acute hemorrhagic shock, is pressure to the source of bleeding, a massive transfusion protocol if they're getting really anemic really quickly. You start with fluids and then move up to that if you need it. You do all the right blood tests, the coags, the group and hold, and all the rest of it, and vasopressors and ICU support early if that's what it's looking like. If it's not that, if it's a miscarriage, for example, then there's counselling and you need to get senior help. I don't think a junior doctor should be leading the management of a miscarriage. There should be someone experienced who's dealt with them before and who can answer the mother's questions, because sometimes they can... At 24 weeks, you probably can't do it at home. You probably need either surgical or medical intervention. Surgical would be a dilation, curettage, or evacuation of the... and hysteroscopy. Medication, if it's earlier, you can consider things like mifepristone, and there are other ones as well, like methotrexate, those sorts of things. But at 24 weeks, I think it's a surgical termination you need to do, or evacuation, I should say, because it's already been terminated if it's miscarriage. So that's if it's miscarriage. If it's cervical cancer, like that's a whole different game as well. So that'll be all about staging and grading the cancer. So you need to take your biopsies. You do the large loop excision of transformational zone. Of course, an intern doesn't do this. This is all in conjunction with senior help, and that might not be appropriate if someone's pregnant. But you want to do biopsies, you want to grade it. They have a CST program now, so you can see if there's cellular, you can see if there's HPV, and you can also do cytology if you think there's something high risk and look if there's dysplasia.
Guys, my camera overheated after that, so it auto shuts off after a while. Which, my bad, I'm new to YouTube, forgive me. But yeah, so there was a couple of things that could be improved on that obstetric and gynecology section. I didn't think it was a complete catastrophe, like I didn't blank and stop speaking, which is kind of the fear that a lot of med students have. So I kept talking. I think YouTube has been helping me practice my kind of articulation and confidence in speaking. I did get pretty harsh feedback from the examiner, and she was tossing up as to whether I failed or whether it was a borderline pass. Her feedback was really about the fact that I didn't focus enough on placental previa, which is the most likely diagnosis in this case. Look, at least I brought it up. I think you'd fail if you didn't bring it up, but if you bring it up and then you show that you're safe and you say that you're going to talk to senior clinicians for advice, then I think that's fair. But anyway, it's not up to me what mark I get. If only it was. So now I've got plenty to study. I'm going to start focusing on obstetrics and gynecology this week and try and build that back up. I haven't studied it for a couple of months, so that's why I'm a bit rusty on it. That's it from me, guys. Have an absolutely lovely day. Bye for now.